Good evening, everybody. So, today I had given a lecture yesterday on respiratory system. So, today we will be doing a continuation and talking about the respiratory disorders. My name is Govindraj, and I am a student of biochemistry. And let's hop on to the subject. So, before going on to the topics, let's see where we left off in the previous class. So, I'll be giving a small recap on the airway or the respiratory pathway, and we'll be looking at some basic terminologies related to the disorders because these terminologies are very important to map out whether one has a specific respiratory disorders by looking at the spirometer data. So here we are going to look at airway first, and then we'll be looking at recoil pressure. What is recoil pressure? And we'll be looking at a term known as compliance. So this compliance has a very important aspect regarding the disorders, and then we'll look at what is a spirometer, and then we'll hope on to different disorders, starting with obstructive ventilatory disorder. Then we'll be looking at a restrictive ventilatory disorder. Sorry, there's a spelling mistake. One Y is missing. I don't know why. Okay, then there will be we'll be looking at bronchitis, emphysema, and asthma. So if I sneeze in between the class, just ignore it. I have a small sneezing problem, and let's start. So yeah. Okay, sir. Airway. First, we are going to look at the airway. So here, the airway consists of the entire path of the airflow from mouth to the alveolar sac. Okay, so here we are going through we start from the nose, and there the scientific terminology will be oronasopharynx, and then we'll be going to the air, not we, the air will be going to larynx, then through trachea it will be going to it will be branched from the trachea. At the end of the trachea, it will be branched to the lungs. So as we know, there are two lungs, so there will be first branching will be from the bronchus. So the bronchus will divide into two, and these bronchus, then in each lungs they will further divide into 5 lobar bronchi, and 3 on the left, 3 on the right, and the 2 on the left. So why this difference in number? It is because of as we know, the heart is situated to slightly situated to one side, so that's why the lung volume is a bit lower in one half of the like in the left half, and it is so because of heart is situated at that portion, the lung is a little constricted. So that's why we have a variation in the number of bronchi branching. And after that, these 5 bronchi, each 5 bronchi that has been branched from the main bronchus will further divide into tertiary bronchus and bronchioles, and that will be like 15 to 20 divisions for each 5 lobar bronchi. And after that, each of these after these further divisions, at the end we'll get the bronchioles, and at the end the functional unit of the respiratory system, that is the alveoli. Okay, so the part of the airway that participates in gas exchange with the pulmonary capillary blood system consists of the respiratory bronchioles, alveolar duct, and the alveoli themselves. So these 3 portions are the active portions where the gas exchange take place. Okay, now the adult human lungs. So if we measure out how much alveoli is there in our lungs, we can see that there is a very fantastic amount of 300 million alveoli, and that is very huge amount. We can like it is very fascinating to know that there is so much alveoli. So and if we look at the total surface area provided by these alveoli, that will be that can actually cover an entire tennis court. Okay, so I think that you will be fascinated by these interesting remarks. Okay, now let's look at what is recoil pressure. So we in the when you heard my first video, you would have noticed that there is a lot of pressure, there is a lot of pressures playing in this respiratory system. That is, we have alveolar pressure, transmural pressure, or the pleural pressure. So there are so many pressures, and we don't know what these pressures are doing. Okay, so we'll look at each pressures, and we'll see how these act. Okay, so recoil pressure is the difference. So first of all, we have to know one thing, that the lungs is situated in the chest or the thoracic cavity. It is like suspended, and it is a hollow. As we know, lungs is a hollow thing, because it is like considered as a balloon suspended from a boat, from inside a bottle. Okay, so the bottle will be the chest cavity, and the balloons with the piping system will be the two lungs. So consider there are two balloons. Okay, so in order for the balloon to what to expand and to get so here the second point, if you notice that to get any hollow elastic structure to move from its resting volume, one side of the structure must be exposed to a higher pressure than the other. So this is just I'll just simplify it for you. If you have a rubber band and you want to extend that rubber band, you cannot extend it without fixing one end of the rubber band somewhere. Okay, so this is the basic this is the basic idea behind this sentence. So if we have our hollow lungs just suspending in the chest cavity, we cannot expand, we cannot make it uh, extend, and we cannot move, retract it. For that to happen, you have to fixate this lungs on one position to somewhere. So this is done by a small pressure created. So that is called as the pleural pressure. So if we, one minute. Okay, so if we look at this diagram, so this is end expiratory stage, that is after we have expired. Okay, expired means not in the sense that we are dead, we have exhaled out the air. So here what are the pressures that are playing here? First, that is the alveolar pressure. So in the previous video, I had told you that at an end expiratory stage, we take atmospheric pressure equal to alveolar pressure. This is for just to make things easier, or else it will be all confusion. Okay, so let's take the alveolar pressure is equal to 0. So we should keep a point fixed, that this lungs is a very elastic subject, that it can retract. If it expand, it will retract automatically, just like a rubber band, just like a balloon. Okay, so so in order for the lungs to retract, what forces play there? That is given by these arrows. So the first arrow we are going to look at is this arrow, 1 2 3, like this arrow. So this arrow shows that it is the inward recoil of alveoli. So the alveolar walls have a tendency to recoil, that it can contract after it has been expanded. So that is a passive process. So this inward recoil is the pressure by which it retracts. So here the alveolar, the recoil is there, but we take the alveolar pressure equals 0. That is, these two are a bit confusing sometimes. Okay, that we'll see when the next we'll look at the other picture. So then there is intrapleural pressure. So the intrapleural pressure is the pressure created inside the pleural cavity. So we know that the lungs is covered by pleura, and between the lungs and the pleura there is an intrapleural cavity, and there is a fluid, that is the pleural fluid. Okay, so this intrapleural pressure creates a suction force that attaches the lungs, like glues the lungs to the chest cavity. Okay, so then we have the this force, or this what we say, uh, the the outward recoil of the chest wall. So this chest, like when we inhale and exhale, the chest uses some muscles to expand and relax. So so the recoil formed by chest compressions and relaxations are known as the chest recoil. Okay, so as atmospheric air enters the alveolar cavity, so there develops an alveolar pressure. This is because when this air gets sucked into the alveoli, the pleural pressure is exceeding. Okay, the pleural pressure is more than the alveolar pressure. So thus the alveolar pressure decreases, and there is a suction created by this. That is why the alveolar pressure drops. So thus when the alveolar pressure drops, this causes the atmospheric so comparatively the atmospheric pressure is high, because the alveolar pressure has dropped to -1. So the air will flow from atmosphere to inside of the alveoli, and thus we get the oxygenated air. Okay, so this is the basic idea. If you have any doubts, just ask me, so that I will try to resolve it. So so let's look at the next point. So next we are going to look at is the compliance of a lung. So compliance refers to the distensibility of an elastic structure. So like every elastic substances has a distensibility. That is, it can expand and relax. So how much it expands and relaxes, this is known as the distensibility of an elastic structure. So our lungs also has this distensibility, and it is defined as the change in volume of that structure produced by a change in pressure across the structure. So this distensibility is can be defined as the change in volume of the structure produced by the change in pressure across the structure. So if we are applying a certain pressure on a structure, and how much volume change is happening in that structure, that is known as the distensibility. Okay, so excuse me. Okay, so it is important to understand that the lung will not increase in size if the pressure within it and around it are increased equally at the same time. So consider a tug of war. Okay, so we have both team A and team B. If the team A and team B are pulling equally, then there will be no change. So same principle goes on with the lungs. So if there is no differential pressure within or around the lungs, or around the alveolar sacs, there won't be any inward movement or outward movement of air. So this is mainly attributed to the compliance of the lung. So compliance of the lungs decreases with increase in volume, because so here what it says is that consider consider a uniform amount of pressure that you are applying to an object. Okay, so you are giving 1 unit of pressure. Okay, and you have two subjects. One is with small volume and one is with a larger volume. Okay, so you have to apply same amount of pressure to each one, and if we apply to the small one, when you apply a unit force, it will give you a particular amount of change in the volume. But if you apply the same amount to the much bigger volume, then there will be comparing to the volume change of the smaller one, this volume will be small. Okay, any doubt regarding this? I think it was clear. Okay, considering everyone got the idea. Okay, so compliance, so here when we talk about the compliance of the lungs, so the same principle goes here. So decreases, so the lung compliance decreases with increasing volume. So as the if the two person have two different volume of lungs, so one man is very big and he has a higher increased lung volume, and comparing to a small person, so the small person has have only he only have to apply small pressure to increase his lung cavity, lung volume, but the larger man has to apply greater pressure or greater inhalation in order to produce a significant change in the volume. So that is what we talk about. That is what we what say that is what the compliance of a lung means. So therefore, as the lung increases in size, more pressure must be applied to get the same increase in volume. So this is the basic idea behind compliance of a lung. So how compliance of lung plays a role in various disease states. So this is very important. This is how we identify different types of disorders of lungs. Okay, so in case of fibrosis, so fibrosis is a condition in which excess the tissues become fibroid. So fibrotic tissues are accumulated, and this causes the lungs to become stiffer. So the elastic nature of the lungs will gradually reduce, and it will become more stiffer. So due to which we have to apply larger pressure in order to expand or change the volume of the alveoli. So thus a moderate, so thus such lung would be considered poorly compliant. Okay, did you get the idea from that? So why we need so why we say there is so why we say that in fibrotic lungs the compliance is very poor? Anyone? Hello, those who are listening, why it is said that the fibrotic lungs are poorly compliant? Hello.
Yeah, hello.
Yeah, Mohit.
So lungs become more stiff, hence more pressure is required to increase the volume. So that's why the
Yes,
compliance is very less.
yes, that's absolutely correct. So the lungs would become more stiffer because of the fibrotic content, and thus it will be we will be requiring more pressure to extend it. So now, in case of, let's look at the case of emphysema. So emphysema, where many alveolar walls are lost. So we will look at it, look into this more detailed in the coming slides when we talk about emphysema. So now let's see. So there the alveolar walls are lost. So this causes a reduction in the extensibility, or not extensibility. This causes the lungs to become more loose and more easily expandable, and thus this nature is known as floppiness. So this floppy lungs will, with only a small difference of pressure, it will begin to expand. So thus, in such kind of lungs that is suffering from emphysema, the compliance will be higher, because only small pressure is required to expand the or expand or extend the alveoli. So this is how the compliance play a role in detecting which kind of lung disorder we are dealing with. Okay. Now, if you look at this curve, it will be more evident that if we look at the lower portion, it's this says that it is high compliant, because on applying a small pressure, it is resulting in a great change in volume. So so the slope will be high, and with a small change in pressure, there will be a much greater difference of volume generated. That is the basic idea. So here, but the curve is more curved, and it produces as much the slope is a bit, I don't know why, because I am terrible in mathematics. I don't know when slope increases or decreases, the this occurs. Okay, so I think if you can see, the slope is more horizontal. So there is much pressure is needed to. So with the same okay, so from the picture, I think they are same pressure difference. So with the same pressure difference, there is only small amount of volume change, but comparing here, there is from about what you say 25 to 60 it changed, but here only from a 90 or 85 to 100, 85 to 100. So there is a significant variation in how the pressure plays a role in changing the volume. That is what a compliance means. So the same idea is given here, where it denotes different disease stages and the distending pressure. Distending pressure is the pressure to expand and relax a structure. That's it. Okay. So here we have the fibrosis. So in fibrosis, there is a small pressure can create only a small. If you apply a pressure, it will give you only small variation in volume. So thus here, if we like so analyzing these kind of graph, we can take the pressure equal. Okay, so take the pressure at this that's a very sloppy line. Okay, so take a straight line like this. So according to my drawing, this line indicates the 10 pressure. Okay, so with the same pressure, how much volume change is happening? So that is we are looking at here. So here this much volume change happened, but here this much volume changes happened, and here this much volume change, that is the highest. So so with a small amount of pressure, we have greater or very big amount of volume change. So that is in the case of sloppy lungs, where it is very easy to expand that thing, that we told in the case of emphysema. So in the case of here, in the case of a normal lungs, we will get a corresponding volume change. So that will be like a standard one. But in the case of fibrotic one, the pressure will create only a small volume change. So if we compare the volume changes, so we have this one is the maximum volume change, and this one is the lower volume change. So this we take as the normal what a normal lungs should be. Okay. Now let's look at what is spirometer. So spirometer is an equipment used to measure the amount of volume of air inspired and expired during a normal and forceful respiration. So here, the as you can see in this picture, we have a mouthpiece. So the mouthpiece, as it says, it will be going into our mouth, not fully inside our mouth, just we'll be breathing through it. So when we attach this to a patient and we will tell him to breathe normally, first we'll tell him to breathe normally, and after that, after getting the normal readings, we will tell him to inspire forcefully or expire forcefully. So thus there we can measure some deviations that uh, so we have the normal values and we get the maximum amount of air that he can take in and take out. So thus we can measure different volumes of air. That means the inspiratory reserve volume, all that we told in the previous class. Okay, so if you have not seen that previous lecture on the respiratory system, please go on. But there is so much mistakes in the English and all. But you can, I think I have pretty well managed to um, talk about this different volumes and all, because there is a graph given in that you can use in reference to this part, so that you can um, understand it more clearly. So this device checks the proper functioning of lungs and identifies any possibility of airway obstruction or disorderliness. Okay, it is the recorded data from this instrument is known as spirogram. Okay, spirometry cannot, however, access information about absolute lung volumes. So um, we cannot fully tell that this much amount of air was inhaled, or that we cannot measure. For that, we have another instrument where the particular gas dilutions. So there we add some different gas, and we hook up it with the patient, and we tell him to breathe in and out that gas, and the dilution of that gas by each time he inspire and expire, this gives an idea about how what volume of air he took in and what volume of gas was diluted in each step. So this is the process by which absolute quantification of these lung volumes is done. But this pyrometer gives us data about different disease stages. Okay, so thus information about functional residual capacity and lung volumes computed from FRC, that is functional residual capacity, such as total lung capacity and residual volumes, must be computed via different means such as body plethysmography or gas dilution. So these techniques are used for calculating the absolute values. Now we will look at different disorders. So first, the obstructive ventilatory disorder. So obstructive, from the name itself, we can get small idea that some kind of obstruction is happening there, and obstruction in the ventilation. So thus we get the obstructive ventilatory disorder. So here the lung is unable to respire normally, okay, because of damaged lung tissues or obstruction on the lung pathway. So this is the main idea. So here the proper respiration is not taking place because something is obstructing the pathway, or because of some tissue damage, some proper functioning is not taking place. That's the idea of obstructive ventilatory disorder. So obstructive ventilatory disorder is like a broad category of disorders. So it includes the emphysema, asthma, and everything. So much of these disorders fall into this category. Okay, so let's look at the characteristics of ventilatory disorder. Here, the respiratory abnormality characterized by a slow rate of forced expiration. So we have a low FEV1. So FEV1, we didn't talk about this in the previous class. So FEV1 is the forced expiratory volume in 1 second. So if we take 1 second, how much of air he can expel out, this is the forced expiratory volume. So how much volume of air one can expire out forcefully in 1 second. Okay, and now we have so the FEV1 to FVC, that is forced vital capacity or functional vital capacity, each one of this. So both of these, so the ratio of these gives an idea about different so this ratio is usually used to identify different disease stages. Okay, and in those, okay, so let's look at some disease stages. In those with active asthma or emphysema, high functional residual volume will be there. That is functionally how much volume of air will be uh, left out in the lungs. That is the functional residual volume. So in case of asthma and emphysema, there will be a high functional residual volume. So if we look at a normal person and a disease or an asthmatic patient, the asthmatic patient will be having more air in the lungs in a static stage. That is, in a normal person, he will be inspiring and expiring air, but only a small amount of air will be trapped inside the lungs. Not trapped, like it is occupying the lungs. Okay, so the next point is the asthmatic patient or emphysema patient will be having high functional residual capacity. So that it is the same idea. And then they will be having low vital capacity. Low vital capacity is because of their inability to respire normally. In individuals with bronchitis, these lung volumes are more likely to be normal. Okay, so bronchitis, there is a different condition is there that we'll look at as we progress through our different disorders. Now, like an obstructive ventilatory disorder, we have restrictive ventilatory disorder.
Please conclude in 4 or 5 minutes.
Sir?
Please conclude in 4 minutes or 5 minutes.
Okay, sir. I'll try my best. So, restrictive disease is a condition marked most obviously by a reduction in total lung capacity. So here the lung capacity is restricted. So restricted ventilatory defects may be caused by pulmonary deficit because of the changes in lung capacities, or pulmonary fibrosis. We talked about the fibrotic case. Okay, so non-pulmonary deficit include I think this restrictive ventilatory disorder is we'll look at this at a later stage because we have some important thing there. So first about bronchitis. So bronchitis, as the name indicates, it is like an inflamed bronchus. Okay, so here the bronchitis is a condition which is clinically defined as a chronic cough with mucus production most month of the year. So here the mucus production will be high and there will be chronic cough because of the obstructed bronchus. So the mucus secretion and the inflammation. So the mucus secretion favors inflammation. So this is because the mucus will trap a lot of pathogenic organisms or microbes, and these microbes may trigger some inflammations, and thus the bronchi tend to narrow the airway because of these inflammations and provide obstacle to the airflow. Thus, this creates an airway resistance. And hello, sir. Some someone is mic is on. Hello. Okay. So in this manner, bronchitis may cause obstructive pulmonary symptoms. So just as we said earlier, it creates an obstruction to the air pathway, and that leads to an obstructive kind of disorder. Now, let's look at what is asthma. So, asthma, the pathophysiology of asthma is that in this condition is characterized by hyperresponsiveness of the airway. So, here, hyperresponsiveness in the sense that it creates a lot of inflammation, and this inflammation leads to different symptoms, not symptoms, different conditions like bronchial smooth muscle tone will increase due to this inflammation, and this inflammation also causes inflammation of the bronchial mucosa. So different layers of the air pathway will cause different inflammation, and as we look into this picture, it shows how these inflammations are concerning our asthmatic patient. So here, the airway smooth muscle hyperresponsiveness, this causes constriction and thickening. So this thickening causes subepithelial. So here, all these things are manifested due to inflammations. So the mucus hypersecretion and impaired mucus clearance. So mucus gets settled in the pathway, and this mucus further aggravates the inflammations and increase the eosinophils and neutrophils. So as the inflammations increases, neutrophils and eosinophils will be recruited to manage this problem, and thus more and more so there will be a lot of biochemical changes, and remodeling of the structures will take place, and thus leading to more chemokines and more prostaglandins will be recruited here, and this causes a further aggravated situation. So thus the total, in a sense, what happens is that the whole the pathway get constricted because of all this inflammation, and all the pathway and the airflow will become very slow. So during episodes of acute asthma, the pulmonary function test reveals obstructive pattern. As we said, the airway is obstructed because of the inflammation, and the reduction in force. So here what happens is that maximal expiratory airflow, that is FEV1 by FVC ratio, as we said earlier, will due to the resistance will decrease, and the reduction in the forced vital capacity, because because the patient is not able to breathe normally, and he can only breathe in, but due to his inability, due to his obstructed air pathway, he will be finding it difficult to expire the air he has inhaled. So thus he will be having more wheezing sounds and all because of these restrictions. So so they must exert significant effort to create extremely negative pleural pressure. So due to this obstruction, he must apply a lot of force to to create a negative pleural pressure in order to inspire and all. So overinflation also reduces the curvature of the diaphragm, making it less efficient in generating further negative pleural pressure. So all this results in a very aggravated situation. So next we'll be looking at emphysema. So here this is also an obstructive respiratory disease which shows extensive damage to the lung tissue, particularly alveolar wall. So the alveolar wall gets collapsed, and this is characterized by dilation of alveolar spaces. 1 second. Okay, so this results in the chronically overinflated lungs and the high total lung capacity. So when the lungs is overinflated, the lungs will correspondingly show a high total lung capacity because it is overinflated. So the lung capacity will also increase, and the functional residual capacity also increase, and also the residual volume because the lungs is overinflated and it is having higher volume than normal, and this lessens the curvature, as we said earlier, and making it less efficient in generating even small wings in pleural pressure necessary for breathing. So in here also, the due to the curvature of diaphragm, because of the lung volume increases, the lung is pushing the diaphragm down, and it reduces the curvature, and thus it causes it will become very difficult to generate pleural pressure in order to execute a normal respiration. So here also the pulmonary function test or the lung functioning test will be giving low FEV1 by FVC. So this is a general character for every obstructive diseases, because in every obstructive diseases the air will be the lung will be having a greater amount of residual volume, and but the in case of emphysema, the main characteristic is that here it will be having low functional residual volume. So the FEV1 by FVC ratio will be low. Okay, so this is how the disease is manifested. So here we can see a normal alveoli. So here we can see well demarcation of the alveolar walls. But if we look at a damaged alveoli, it will be having collapsed walls, because we cannot see this wall. So this is collapsed, and we are lacking these walls. So this causes easily inflatable alveoli. So that is what is known as the floppiness. So the floppiness of the alveoli increases because of these wall destructions, and thus a small pressure will create a large volume changes. So that is what is seen in this graph, and because of this the vital capacity and all will be increased than the normal, but residual volume will also increase. A large number of leukocytes, and so what happens in how these elastic tissues get destructed. So this is done. This is mainly due to one enzyme known as elastase. So this elastase, what it does is that it cleaves the elastic tissues, and this is functionally a protease, and large volume of leukocytes are recruited by macrophages, and these leukocytes will further recruit these proteases to cause the destruction. And this disease is also characterized by reduced ciliary movement and mucus obstruction of air passage. That is why the FRC is seen higher. Now let me summarize today's lecture. Yeah. So the main thing we can take out from this is that pulmonary tests are very important to understand the physiology of respiratory disorder. And the next, because pulmonary test means spirometry or the lung functioning test. Okay. Now, the next point is that differences in lung volume and capacities give idea about the nature of disorder. And this is the most important thing. The pathology of respiratory disorders glimpses to the role of inflammatory responses in the formation of diseased status, and negligence of the primary signs may lead to cancers and other lethal conditions. So, because of many lifestyle changes and all, we are looking for we generate some bad habits to ourselves, and this results in inflammation, and this inflammations, if it aggravates, may lead to different disease conditions. So major factors contributing to respiratory disorders are lifestyle choices and personal hygiene. So one of the major one is the smoking. So quit smoking if you want to have a very good healthy respiratory system. So that's it. So thank you. And if you have any doubts, please.
Thank you. As you, many of you know that